Okay, let's just wait maybe a few minutes for other participants to join, then we will proceed with today's presentation. I think we can start. So, good afternoon and good morning to all of you who today joined the meeting for our Saturday session. My name is Dr. Naod. I have joined this fellowship for about a year and a half, maybe 2 years now. I am the leader of the Gold team, and we have decided to conjoin the new fellows from the Gold team so that they will have an effective session with us. Today, I will be mentoring and leading the group about the presentation of 4 topics. And also, we'll go through some interview tips and also a little bit of guidance for those who joined the program a bit later this year. I will try to speak about how to proceed with this program, how to join groups, how to assign yourself to research presentations, and also how to make network within this fellowship. So as per our schedule today, the first presentation is going to be about polypharmacy in older adults, and it will be presented by Dr. Alaa, Dr. Rawan, and Dr. Essra. And I hope they are here. I can see Dr. Alaa, Dr. Rawan. So I will try to share the PowerPoint presentation and we will proceed with our today's session. And thank you. Can everyone see my screen? Can you
Yes.
guys see my screen?
Yes, we can see.
Okay. So our first presentation is going to be about polypharmacy, and the presenters will take it from here. Thank you. Is Dr. Alaa, Rowan, or Isra here?
Yes, we're here, but Dr. Syeda to start first.
Hello, hi.
Hi, we can hear you. Can you see the
Hello,
screen?
hi. Yeah, I'm Essra. I'm going to start the presentation about the polypharmacy. Okay. Hello, everyone. Today we're going to present polypharmacy in elderly, me, Essra, and my colleagues, Rawan and Alaa. Okay. Polypharmacy, defined by WHO as the administration of many drugs at the same time or the administration of any excessive numbers of drugs. Are you guys first hearing me well?
Yes, we can hear you.
Okay, all right. So It's a frequent among an elderly, or they are often suffer from chronic diseases with concomitant pathologies. That's why elderly are more vulnerable to polypharmacy. Okay. What leads to polypharmacy and the contributory factors to polypharmacy? Contributory factors to polypharmacy can be divided into two parts: patient-related factors and healthcare-related factors. First thing in patient factors, the age. That's why people more than 65 are our target group due to their multimorbidity. Intellectual disability can lead to use of many drugs too, frequent healthcare visits, and acute hospitalization. And in healthcare setting, due to multiple providers, that's why sticking to one primary care physicians can lead to decreased risk factors for polypharmacy and also medication errors. So if polypharmacy always means it's harmful to the patient, or it always means inappropriate to use polypharmacy, no. If the medications have clear indications, polypharmacy here considered appropriate to use. Medications that are safe in older adults are also appropriate to use, and medications that are aligned with goals of our care. And once we consider polypharmacy as inappropriate, if there is no clear indications like using BBI in patient not diagnosed with GERD, or medication listed on Beers criteria, and I'm going to talk about Beers criteria later on in my presentation, and medication that are at odds with goals of care. Why do we care about polypharmacy, and why polypharmacy? It's a big deal because polypharmacy can lead to bad consequences like adverse drug interaction, drug-drug interactions, decreased medical compliance due to non-adherence, unnecessary drug expenses on a patient or in a healthcare setting too, and can lead to poor quality of life and outcomes. How do we assess polypharmacy? Okay, first we have to start by medication review. Regularly evaluate all medications, including the OTC drugs, supplement, and herbal drinks. When we see polypharmacy, we don't just means the prescribed drugs by the doctor, even the over-the-counter medication, the supplement the patient use, and even the herbal drinks due to the sometimes interactions between herbal drinks, supplement, and the other drugs with prescriptions. We have screening tools we use like BEERS, STOP, and STAR to identify the potentially inappropriate medications. And lastly, have a detailed history about the patient to assess for indications, contraindication, and side effect for all medications. Okay, I'm going to start about the first criteria, BEERS criteria, and what does it mean. Okay, the American Geriatric Society BEERS criteria for potentially inappropriate medication use in older adults is a list of medication guidelines that helps healthcare providers safely prescribe medications for adults over age 65. When we talk about BEERS criteria, we have 5 sections. Medications to avoid if you are over 65 years of old and you are not in hospice or palliative care. What does that mean? We have their medications that are not considered safe to use when you are 65, but in some circumstances like living in a hospice or being in palliative care, we can use them according to the patient health conditions. Medication we're supposed to avoid among people with certain health conditions, and medications to avoid that can lead to drug interaction with combined together, medications to avoid due to harmful side effects that outweigh the benefits of the drug, and lastly, due to kidney function and renal impairment in the patient. Okay, top. What medications are on the BEERS criteria? There are close to 100 medications or medication classes listed on BEERS criteria. I'm going to give brief examples. The following list is not comprehensive, but it gives examples of drug in each category and the reason why it's harmful to use in elderly. First example is analgesic like mepridine. It can lead to neurotoxicity and can precipitate delirium in elderly. Antihistamines due to their cognitive impairment, and especially when combined with other drugs that can affect the cognition, like anticholinergic. That's why we avoid to combine them together. Antihypertensive like alpha blockers due to their hypotension effect, and antibiotics, especially in patients using warfarin due to their effect that lead to increased bleeding. That's why patient with warfarin, we give them like a clear instructions and interactions with other drugs like antibiotic. So does that mean every drug mentioned in Beer's criteria, we have to stick to it and we don't combine them together? No. That's why using Beer's criteria have some potential risk. Beer's criteria focus on a wide population to identify safety risk of prescription medications because of the range of data. It's not a person specific. The Beer's criteria doesn't take into considerations a person's general health and underlying medical conditions or circumstances. That's why it may lead to a healthcare provider to choose a specific medication. Because of this, the Beer's criteria is a tool that providers can use, but it's not something that makes decision on behalf of a skilled and experienced healthcare providers. I'm going to explain this with the previous example. Does that mean patients with warfarin, they are not supposed to use antibiotics? No. But if a patient on warfarin and he have some bacterial infection and supposed to have antibiotics, we have to adjust the warfarin dose according to the antibiotic. Is it enzyme inducer or enzyme inhibitors? We have to monitor the patient INR and so on. Here are some examples for drugs that they are not supposed to combine together due to their interaction, but in a specific circumstances due to the patient health and according to the healthcare vision, we can use them together. The first example is ACE inhibitors and ARBs. The general concern about using these drugs together because these both drugs can activate the renin-angiotensin system to manage high blood pressure. So they increase the risk for kidney injury, hyperkalemia, and low blood pressure. But in specific cases, like in rare cases of heart failure, some doctors may combine these drugs together under close monitoring to achieve optimum blood pressure control or heart protection effect. Another example, using of NSAID and corticosteroid together. Both of these drugs increase the risk for GI ulcers and bleeding, especially in the long-term use. But in specific cases, like inflammatory condition, rheumatoid arthritis, we can combine these drugs together for a short term, and we can avoid their adverse effect like GI ulcers by providing another medication like BBI to block the stomach. And this is how Beer's criteria work, and we can get the best advantage of it. It's helped us to know the interactions and the contraindication of using the drugs together. Plus, we put in our mind the patient conditions and the healthcare vision. We combine all that together, and we have the best results when we all know that. Okay. And I hope I have explained everything clearly. I have to stop here before my other colleague Rawan continue with the others criteria. So please feel free to ask any question before we go so on in our presentation.
Thank you, Dr. Alaa. I think Dr. Rawan can proceed from here.
Okay, thank you.
Hello, my name is Rawan. Today I will continue the presentation and I will talk about the STOP criteria and the START criteria. We'll start by the STOP. STOP is a screening tool of older persons' prescriptions. It's a tool used by healthcare professionals to identify potentially inappropriate medications in older adults. It serves to improve medication safety by evaluating prescriptions that may pose risk, such as adverse drug reactions, increased hospitalization. And the criteria covers various aspects, includes drug duplication and dosage issues. There are some examples. I will talk about some examples, like in the cardiovascular system. Digoxin at a long-term dose, more than 125 microgram per day, with impaired renal function, it's not recommended generally in older adults. And in central nervous system, tricyclic antidepressant is not recommended with dementia or glaucoma or constipation. Stop criteria are often used alongside the start, which will I talk about in a minute, which identify underutilized medication to optimize overall pharmacotherapy in elderly patients. Start criteria. You can proceed to the next slides. The next.
Can you see the screen?
In the GI system, in the stop criteria, there is another examples like diphenhexylate and loperamide for the treatment of diarrhea of unknown cause. It's also not recommended. In the respiratory system, theophylline as monotherapy for COPD also. In musculoskeletal system, NSAIDs with a history of peptic ulcer disease or GI bleeding, unless with concurrent H2 receptor antagonist. It's not recommended. Urogenital system, bladder, antimuscarinic drugs with dementia. It's not recommended to be taken in elderly. And endocrine system, beta blockers in those with diabetics mellitus and frequent hypoglycemic episodes. Next slide. Also, in the stop criteria, drugs that adversely affect those prone to falls, like benzodiazepines and neuroleptic drugs, should not be generally given to elderly. And in analgesic drugs, use of long-term powerful opiates as a first-line therapy for mild to moderate pain should not be given unless necessary. And in duplicate drug classes, any duplicate drug class prescriptions like concurrent opiates or NSAIDs or SSRIs are generally not preferable to be given. The start criteria, which I talked about that is used with the stop. Start is a screening tool to alert to right treatment, is a tool designed to identify potential prescribing omissions in older adults, ensuring that necessary medications are not overlooked. It highlights evidence-based recommendation for starting medication that may benefit elderly patients based on their conditions, such as cardiovascular disease, diabetes, and osteoporosis. Start is used alongside the stop to provide comprehensive approach to medication management in older adults, promoting safer and more effective pharmacotherapy by addressing both under and over prescribing issues. Examples for the cardiovascular system preferred drugs, warfarin in the presence of chronic atrial fibrillation are recommended. Respiratory system, regular inhaled beta-2 agonist or anticholinergic for mild to moderate asthma or COPD should be given. And in the central nervous system, L-DOPA in idiopathic Parkinson's disease with functional impairment and disability, it's recommended. And in GI system, PPIs with severe GERD or peptic stricture requiring dilation are generally preferable. And in musculoskeletal system, disease-modifying anti-rheumatic drugs, for example, should be given for patients with active rheumatoid disease lasting more than 12 weeks. In endocrine, metformin with type 2 diabetes plus or minus metabolic syndrome should be given generally. Thank you. Alaa will proceed from here. Thank you.
Thank you.
Hello everybody. My name is Alaa Azahir, and I'd like to review with you some cases. So, let's start with the first case. It's about a 74-year-old obese African American female, height 5 feet 6 inches, which equals to 167 centimeters, and weight is 90 kilograms, has a past medical history of chronic kidney disease stage 2, glaucoma, heart failure with reduced ejection fraction, hyperlipidemia, hypertension, osteoarthritis, and type 2 diabetes. The patient also occasionally complains of constipation, heartburn, and insomnia, for which she takes medications as needed. She has no known drug allergies. Based on the latest medication profile, the patient is receiving the medications listed in Table 1. Next. This is the list of medication the patient is currently taking. For constipation, the patient is taking Dr.Syeda. For glaucoma, timolol. For heartburn, the patient is taking famotidine, calcium carbonate, and antacid. For heart failure with reduced ejection fraction and hypertension, the patient is taking carvedilol, furosemide. For hyperlipidemia, atorvastatin. For insomnia, zolpidem. For type 2 diabetes, metformin. For osteoarthritis, acetaminophen, and ibuprofen. The following relevant vital signs and laboratory data are provided for this patient. The blood pressure is 150/85, which is kind of high. The heart rate, 78 beats per minute. The renal function and electrolytes, regarding the serum creatinine, it's 1 milligram per deciliter. The blood urea nitrogen, 15 milligram per deciliter. The urine albumin to creatinine, very high, 300 milligram per gram. And the GFR, 64, which is low. The normal is 90 to 120. And the serum potassium, 3.5. Regarding the lipid profile, the cholesterol, total cholesterol, 245 milligram per deciliter. The HDL is 55, the LDL 190, and triglyceride 150. So all lipid profiles are high. Regarding the liver enzyme test, all of them are normal. AST and LT are in normal range. Case-based analysis of potential inappropriate medications. When we take timolol and carvedilol, both drugs are non-selective beta blockers. Timolol and carvedilol are used for ophthalmic and systemic indications respectively, and the combined use may result in additive cardiovascular effect like bradycardia and hypertension. Beta blockers may also mask the signs and symptoms of hypoglycemia in patients with diabetes. So how we are going to manage this situation? By increasing the monitoring of cardiovascular and glycemic effects as advised. Regarding metformin, as we all know, metformin is renally eliminated, and patients with chronic kidney disease and unstable heart failure may be at increased risk of adverse effects such as lactic acidosis. So we have to monitor the signs and symptoms of lactic acidosis, and we can consider alternatives for patients who have type 2 diabetes and also have worsening events of kidney function or unstable heart failure. Regarding zolpidem is the metabolism product of this drug changes in female and older adults, and resulting in a prolonged or unexpected side effects like, for example, sleep, walking, and next day impairment. And to manage this, we have to consider a dose reduction in this patient, or to use an alternative therapy like ramiltion, the melatonin. Atorvastatin, it's 10 to 20 milligram daily is a moderate intensity statin dose. For this patient with several high risk conditions for future atherosclerosis, like this patient has high LDL, type 2 diabetes, hypertension, age more than 65, and heart failure, we can consider giving this patient high intensity statin, but we should first evaluate the risks versus benefits of high intensity statin dosing, 40 to 80 milligram daily of atorvastatin. Regarding ibuprofen, NSAID, especially in older adults, may result in adverse effects such as nephrotoxicity and GI bleeding. We have to avoid it if possible. The use of NSAID in chronic kidney disease in older adults is very harmful, and we can consider alternative drugs such as acetaminophen. And the last is Dr.Syeda. There is no efficiency regarding the data in older adults, and we can consider discontinuing the products to minimize the risk of polypharmacy-related issues. Next case is about an 8-year-old woman taking multiple medications, including antihypertensives, diuretics, and sedatives. What side effects might this patient experience as a result of the current medication? So these medications can lead to dizziness, hypertension, and sedation, which will increase the risk of fall in this patient. What are the appropriate intervention? Well, first, we have to do a good medication review, and this should be done by conducting a thorough medication review with a pharmacist to identify the potentially inappropriate medications and explore the alternatives. And we can involve discontinuing or adjusting the doses of sedatives and diuretics. The second is fall risk assessment, and this should be by implementing a comprehensive fall risk assessment to evaluate the environmental hazards and physical function. The third is education. We have to educate the patient and caregivers about the side effects of medications and the importance of reporting any new symptoms. The fourth is strength and balance training, and this should be by referring the patient to physical therapy for a tailored exercise program, focusing on the strength and balance to enhance stability. And finally, home modification. And this by removing the tripping hazards and installing grab bars in critical areas like the bathroom. The management strategies for polypharmacy in elderly include, first, this de-prescribing, which means gradually reducing or discontinuing the unnecessary medication, simplifying regimen by aiming to once daily dosing or combining therapies when appropriate. Patient education, as we said, involving the patient and the caregivers in discussion about the medication, focusing on understanding the benefits and risks, and interdisciplinary approach by collaboration with pharmacists, geriatricians, and other health providers for holistic care. So in summary, polypharmacy in elderly is necessary evil, although it's inappropriate, but the inappropriateness should be judged in a case-to-case basis. Necessary tools should be used to avoid it, and optimal prescription is the key. So now we come to the end of our presentation, and we hope you found it valuable and informative, and thank you for joining us.
Thank you, everyone, and thank you to all of you. That was a very precise and to the point presentation. Just to sum it up, as briefly explained by the presenters, nowadays, especially as a primary care provider, you have less power to alter any kind of medication in which was previously prescribed by subspecialties such as endocrinologist or nephrologist or psychiatrist. So in terms of polypharmacy, if you feel as a primary care provider or as someone who just starting to practice medicine, if you feel that there is a good benefit of the patient being on multiple pharmaceutical drugs, I think you can proceed and continue with whatever regimen the patient is. But at the same time, if you feel that a permanent medication which has been prescribed by a subspecialty might interact or might damage the patient overall health status, I think good communication with the subspecialty to come to a better conclusion or better health outcome for the patient would be nice. So this will be the end of the first presentation. If you have any question, you can unmute yourself, ask, or maybe you can text in the chat. If not, then we will proceed to the second part of the presentation. Okay, if there is no question, then we'll proceed to the second part of today's session, which is going to be about rehabilitation, PT, OT, and speech therapy. And it will be presented by Dr. Reem and Dr. Fatin. Dr. Fatin is the new leader for the newly formed Gold team, and she's been very helpful in integrating this presentation. And I will stop sharing my screen, and she will start sharing the PowerPoint presentation, and she will take it from here. Thank you.
Thank you, Doctor. Dr. Reem, you can share your screen. Hello, everybody. Can you hear me?
Yes, we can hear you. You can start sharing your screen so that we'll be in control of your slides.
Okay. Just a minute. Can you see me now or not yet?
Not yet.
Okay. Okay. Let's proceed there. Hello, everybody. My name is Dr. Reem Nasraddin. I'm graduated from Ahfad University for Women. Now I'm doing my
Dr.
steps.
Reem, we can see your screen.
Yeah, I'm not sharing yet.
Okay, good.
Yeah.
Do you want me to share it, yeah, doctor?
No,
Dr. Reem?
no, thank you.
Okay.
Now I'm sharing my screen. Is it visible for you guys?
Yeah, it's clear now.
It is visible, yeah.
Okay, hello everybody. My name is Dr. Reem Nasraddin. I'm graduated from Ahfad University for Women. I'm doing my step now. Thank you so much for being here, attending my presentation, me and Dr. Fatin. Thank you, Dr. Nadir, for giving us this opportunity to be a part of this fellowship. Our main topic today is talking about rehabilitations. By the end of this session, you are being able to describe a systemic approach to assess of cause of disability, advantage and disadvantage of potential side of rehabilitation care, role of interprofessional teams and care plans, and to understand how to adapt care to comorbidity and disability, and finally, a basic requirement for rehabilitations of common conditions. So this is our map for today, our way to rehabilitations. We are going through 7 steps, starting from introductions, a conceptual model for geriatric rehabilitations, the site of rehabilitation care, teams and roles, impact of comorbid conditions, approach for diagnostic specific rehabilitation and modality aid, and like the environmental modifications. Finally, we are going for summary and references. So, what is rehabilitation? Rehabilitation is a treatment designed to facilitate the process of recovery from injury, illnesses, or disease to as normal a condition as possible. Let us see this graph. It's contained of 2 axes. The vertical axis it's from up to down, from the optimal self-dependency persons to partially dependent, and ending by total dependent. The horizontal axis it's like a timeline starting from the event, which is a sudden event. It can be like an accident, a stroke, or any illnesses that lead to person for disability. What we mean by the disability? When we're talking about disability, we mean that any restriction or lack of ability to perform a task expected from a normal person in the same age, sex, and social circumstance to do it. After this event, our craft is emphasized that early rehabilitation play a crucial role in restoring personal independence after the event leading to disability. Without the interventional, the individual may remain dependent or see a limited improvement. So rehabilitation is the main core of gaining person function. WHO Global Disability Action Plan objective to remove the barrier and improve access to health services and programs, and to strengthen and extend rehabilitation, habitation, and access assistive technology, assistant and supported services, and community-based rehabilitation to strengthen the collections of relevant data and support research on disability related services. So WHO have like special classifications. It's called ICF. ICF is it's a it's like the abbreviations for International Classification of Functional and Disability. It's like a framework sheets. The main objective of it is to provide a specific basis for underlying health, provide a common language for health-related disciplines, and enable data comparison, provide a systemic coding system. It's like checklist. You can go to see it if you want more details. I put the link at the reference. And they are defining the geriatric rehabilitations as assess the status and need of patient, matching a treatment with specific conditions, and evaluating rehabilitation's outcome. طيب. The conceptual model for geriatric rehabilitation, always it's like complete circles, aiming, restoring functions, relieving pain, preventing feature injury, personalized approach in time and patency. So the disability and functioning are viewed as outcome of interaction between health conditions, the disease or disorder or injury, and the contextual factors like the environmental factors and personal. What we mean by that? The environmental factors, it's range from the person most immediate environmental, like his room, his house, his like the furniture in the room, how to access, how to bed, and like that. Moving towards the general, like the access of transportation, the parking lot in any facilities or anywhere, and the personal factors like age, race, gender, and the education, and even the personal lifestyle. So the site of rehabilitation care, it could be an inpatient or an outpatient. Inpatient rehabilitations, hospitals, freestanding, or it's like a department that attached to acute hospital, skilled nursing facility, or like the outpatient one, hospital-based clinic, independent clinic, or day hospital setting, or even at home. Okay, we are going to just take some of the inpatient sites or the outpatient sites and the level of care requirement and expected of intensity of service and the payment source. Inpatient, the freestanding rehabilitation hospital or a rehabilitation unit attached to the acute hospitals, we are requiring to be at like 24-hour availability of the physician and with training experience in rehabilitation, 24-hour nursing care intense level of rehabilitation services, interprofessional team, and like that. The expected intensity of services and interprofessional team approach is required, and in most cases, this is called for a 3 hour of therapy 5 times per week at least within 2 therapists. This can be physical, occupational, or speech therapy in any combination. Medicare Part A will cover this. from day 1 up to day 60, full coverage. After that, up to 90 days, it's partially covered with daily copayment. More than 90 days, there is a daily copayment for up to 60 lifetime service day, and more than that, there is no coverage. The Medicare, it's like the government health insurance. It's applicable to some persons, the other one at some age and some circumstance. Also, the Medicare Skills Nursing Facility or the Transitional Care Units, we are expecting to find physician supervision with access of 24-hour day on emergency basis, or 24-hour nursing care, less intense therapy needed, interprofessional team coordination, and ideally will occur maintenance of function without progress can be goal of care. We are expected intensity of service daily therapy 5 days per week, 1 hour per day or more, and as tolerated by the patients. The activity, daily life, assistance, and or skilled nurse care. Also, this is covered by Medicare Part A from day 1 to day 20 with full coverage. From day 22 to 80, it's partially coverage with co-insurance, and more than 80 days, there is no coverage. In outpatient setting, the home health, face-to-face physicians visits within 90 days to establish need and order physician certified need and plan of care every 60 days. Skills needed required for homebound patient, including either intermittent skills nursing, physical occupation, or speech therapy. Expected intensity of service, it's intermittent nursing or therapy provided in home, can be more than 7 days per week or 8 hours per day. Patient must have support system to meet the need of living at home. It's also covered by Part A Medicare. The clinic, hospital-based or independent, it's an outpatient rehabilitation site. The level of care required, physical order skills need requirement, rehabilitation services to include physicals, occupational or speech therapy, and view plan periodically. We are expected intermittent physical, occupational therapy, or speech therapy, provided patient must be able to get therapy visits. It's covered by Medicare Part B. There are annually caps on coverage, but these can be waived if medically necessary. So, how we choose the site of care? Each site have advantages and disadvantages for the patient. For example, the inpatient, most intense, but may not endurable for our older patients because they require more than 3-hour active therapy per day. The skills nurse offer 24-hour rehabilitations for who cannot care of themselves or do not have a full-time caregiver. The outpatient, it's preferred. Some patients prefer to return home, and day hospitals need transportation, and it's highly cost and time consumable. But the accumulating data show that the correlation between the site of care and outcome. So when we start earlier, we can get more benefits, and the inpatients, it's more benefits. Always, the physician should consider a severity of an impairment need for ongoing medical management, functional status, ability with stand active social support, need for full-time caregiver, and the insurance plans of the patient. Okay, let us move to teams and roles. Goal of interprofessional team to ensure a patient receive efficient and effective care consisting of comprehensive assessment and interventions for the disabling illnesses and comorbid condition, specific impairment and environmental factors that may affect the activity and the participation. Always, patient and family are the core member of the team, and their expectation and preference must be considered. Each healthcare professional evaluate the patient, identify a goal, then provide a discipline, specific interventions, and to address the patient issue. So, also in team, we have a nurse, physician therapy, occupational therapist, speech therapist, language therapist, and psychologist, dietitians, and nurse practitioners. We are going to address the roles of rehabilitation team. We are starting by the physicians. It should be certified rehabilitation need. It supervise the patient treatment. Excuse me. Treat medical comorbidity, educate the patient and family. Sorry. Physical therapist assess the joint range of motion and muscle strength. Assess the gait and mobility, provide appropriate assistive device, treat with the physician modality. They have the heat, cold, ultrasound, massage, electrical stimulation. Sorry. Assess the environmental barrier in planned discharged environment. Occupational therapist assess the activity of daily living. It's like the feeding, the cleaning, and the instrumental activity of daily living, like using the cell phones, the house working, and like managing the financial of the patient, going through the public transportation or that things. All of it is assessed by the parcel index. It's like frame sheets to assess these skills. You can see it. We will put the access for it at the end of the session in the reference. Also, it is screening visual perceptions and cognitions, provide home access assessment, provide self-care skills training, make recommendation and provide training in using assistive technologies. Speech therapist assess all aspects of communication, assess a swallowing disorder, treat communication deficit, recommend change in diet, and positioning to treat dysphagia. Psychologist to provide clinical and counseling services to the patient and family. The social worker evaluate family and home care factors, assess psychological factor, provide counseling. The pharmacist conduct through medication review, detect the therapeutic incommunicability, reduce of of or eliminating unnecessary medication use, and the process make and makes and fits prosthetic limb. The dietitians assess the nutritional status of the patient, recommend dietary changes to maximize nutrition. Nurse aide or clinical nurse specialist, they are providing ongoing assessment of signs and symptoms, illnesses, medical conditions, and effect, educated patient and family, evaluate self-care skills. The nurse aide assists in activity of daily living and assesses patient mobility, takes vital signs, measurement. And finally, we have the case manager, assisted patient and family in coordinating service to meet the recovery needs and transition toward discharging to home. So let us move to impact of comorbid conditions or the impact of comorbidity upon the rehabilitation. Comorbidity may interrupt or delay treatment and often require adaptation in care plan. Let us give like examples. Patient with schizophrenia has a hallucination regularly, so it's forget his medications. He live in like the group home, have a major difficulty with keeping his room clean, managing many money or grooming, so he's not able to work, and definitively his need it's going to be more than that of have like life modifications, have a family to support him, have a social worker, or have a rehabilitation program. Many of illnesses that can interfere with the rehabilitations of the older adult are predictable and preventable. A systemic approach to assess, prevent, and managing of comorbid conditions improves the chance of maximum benefit from rehabilitation. Let us take some specific comorbidity like reduce mobility, high risk of skin breakdown resulting in pressure ulcers. So the clinician should monitor the pressure and weight bearing area, modifying footwear, wheelchair, or bedding as needed. The thromboembolic event, we should always give like the prophylaxis against to be a part of our routines. Incontinence, structure approach to assess and treat of the bladder problem should be incorporated into rehabilitation services. So, inducing catheters increase risk of infections and rarely appropriate for a non-acute setting. Pneumonia, risk is increased by inactivity, disorder of swallowing, or underlying lung disease. Clinicians should be aware of risk of aspiration and modify diet as needed. Anemia, it's associated with adverse outcome, including functional impairment, decreased muscle strength, poor quality of life. Cognitive functions, um, mental functioning is a critical for rehabilitations, which requires the ability to follow commands and learn. Clinicians should be alert for delirium and screening for mental status and easily reversible causes. Depression, it's endemic in newly disabling individuals, can be manifest as low modification. Always clinicians should screen for depression. Seizure can be can develop after stroke, especially can develop during stroke recovery. So we should give like muscle relaxants or even botulinum toxin so that can be relieved. I'm going to stop here. My colleagues, Dr. Fatin, will continue the presentation. Thank you so much for being here. If you have any question, you can proceed.
Thank you very much. And Dr. Fatin will continue from here, and we will accept questions after the session for this presentation of the rehabilitation is done.
Hello, everyone. Can you hear my voice?
Yes, we can hear you.
Oh. Just I want to share my screen. As my screen is clear?
Yes, it is clear.
Okay. I'm Dr. Fatin Mohammed, MBBS holder from University of Khartoum, 2022. Now I'm working as house officer at Ben Suef University Hospital in Egypt. I will continue our way to rehabilitation. Dr. Reem stop in step 4. I will start from step 5, which is approaches for diagnosis and specific rehabilitation of certain conditions, mobility aids, adaptive methods, and environmental modifications. Adapting care to comorbidities and disabilities. Comorbidities may interrupt or delay treatments and require care plan adaptations. Predictable and potentially preventable illnesses can interfere with older adult rehabilitation. A systematic approach to assess and to prevent those comorbidities will enhance the rehabilitation outcomes. We will discuss common rehabilitation issues that are associated with certain conditions like stroke, fractures, amputation, and cardiovascular diseases. And in all those conditions, our goals of rehabilitation is to address commonly encountered issues like pain management, mobility challenges, and cognitive deficits. It's to focus on maximizing functional independence. How? By training the patient to maximize independence in daily activities, facilitating the patient's and family's psychosocial coping and adaptation, and also preventing secondary complications, as Dr. Reem mentioned, like pneumonia, UTI, deep vein thrombosis, bed sores, and the most important things is the psychological aspect. As you see here in this slide, this is an older man, an older adult patient with a healthcare team discussing care adjustment. The first condition we will talk about today is the stroke. As you know, people age 55 and plus are at the highest risk for stroke-related morbidity and mortalities. And actually, those people will suffer from residual neurological issues. So the main goal in rehabilitation of a stroke is to help those people to regain function and to adapt to functional losses, preventing secondary complication and assisting them to reintegrate into the community. How? By support groups, psychological support, making home modifications, skills training, adaptive devices, and mobility aids. As you see here, this is a stroke patient working with a physical therapist. The most important things as we are approaching a patient with a stroke is to prevent the recurrence of the stroke. Actually, most of the patients who has had stroke is at a high risk of recurrence. So in the rehabilitation phase, the most important things is to ensure the assessment and the treatment for stroke to prevent the recurrence. How? By assessing the risk factor, such as carotid stenosis, atrial fibrillation, and if the patient needs anticoagulant. And definitely the most important things is lifestyle modifications, quit smoking, adherence to medications, regular exercise, and limit alcohol use. And as we know, the most important two risk factors is hypertension and smoking. So we have to advise the patient to stop smoking and to control the hypertension by different medication, SA inhibitors, and also using of statin and antiplatelets will help to prevent the recurrence. The second condition is the hip fracture. Actually, it affects 300,000 people annually in US, and most of those people, the fracture is caused by falls, and the mortality rate is very high. It's account for 5% during hospital stay, and 25% within a year post-fracture. The people at risk for hip fracture are women, white race, those who are using steroid therapy. The main and the most important goal in rehabilitation of hip fracture is early mobilization. Early mobilization is our aim, and pain management. Why? To prevent the complications following the fracture. So early surgical repair, I mean within the first 72 hours, will reduce the mortality and the complications. And there are different types of surgeries, and the surgical options will vary based on the fracture type, either femoral neck fracture or intertrochanteric fracture. But as I say, early mobilization is a key factor that influences the recovery from hip fracture. The third condition is lower extremity amputation. Actually, most of the patients have systemic vascular disease, and the mortality is up to 50% in the first 2 years. And they found that most of the patients will have amputation of the contralateral limb within 2 years. So the most important things when we addressing a patient with a lower extremity amputation is to address and to assess the risk factors, the underlying disease like diabetes. Why? To prevent the amputation of the contralateral limb. And the most important things also in the rehabilitation is the psychosocial support. It's very crucial during the recovery process. And also we have to assess if the patients will need prosthetic devices like this one, this above knee prosthesis, and this is below knee prosthesis. And also there is important things regarding taking a decision of amputation. An amputation surgery generally will aim to preserve the knee. Why the aim is to preserve the knee? Because below knee amputee has a much lower energy requirement of walking than the above knee amputee. Below knee amputee carry much lower energy requirement than above knee amputee. That is why the aim in the surgery is to preserve the knee. But the distal amputation associated with poor wound healing. So we should take careful decision regarding the amputation. The distal amputation associated with a poor wound healing, and the proximal amputation associated with high energy requirement for walking. So we have to wait between those two things while we are taking decisions for amputation. The fourth condition is the total hip and knee arthroplasty. Actually, joint arthroplasty is the most common elective surgeries in US. It's account for 400,000 annually. And the most common cause of these hip and knee replacement is osteoarthritis, followed by rheumatoid arthritis. And the main goal here is to improve the mobility of those patients. It's to relieve the pain and to regain the function. And as we know, the most important diagnostic tool is X-ray and the plain radiographs, as you see here. It's to assess the severity of the joint damage and if the patients will need replacement or not. After the surgery, the most important things is early mobilization and pain control and anticoagulants. Look to this picture. This patient is using a machine called CPM machine, continuous passive motion machine. This machine is a device used to help patients recover from joint surgery. Why? to prevent stiffness, to promote the healing, and to improve the flexibility of the joint. Shoulder rehabilitation, shoulder disorders often impair the activities of their living. So the conservative treatment for shoulder problem and shoulder disorders is very important, either by passive or active range of motion. Like this patient, he is doing a shoulder exercise for certain shoulder disorder. Cardiovascular diseases and rehabilitation. Patients with poor cardiac output may have extreme exercise limitations. An abnormal gait in patients with coronary artery diseases may worsen the coronary symptoms. And unfortunately, if the patient have one vascular disease, he often has others peripheral vascular diseases, like painful feet and high risk of skin breakdown. So these patients have a lot of limitations to practice exercise. So the main goal in cardiac rehabilitations is an individualized, supervised exercise program with a focus on psychosocial, nutritional, and risk factor reductions to improve the quality of life and to reduce the mortality. This patient is undergoing cardiac rehabilitation by treadmill walking with his doctor. Do you have any question? Okay, let's continue the mobility aids. We have cane. We have a lot of mobility aids. Cane, crutches, walker, and we will go through them briefly. The first one is the cane. Cane supports 15 to 20% of the body weight, and it's used in a hand in contralateral to affected limb. If a person has an injured or weak left leg, they will use the cane in their right hand to provide better support and balance in the contralateral limb. The degree of support, it increases with increasing number of tips. Those are called tips. Those are the tips. Those are the tips. As the number of the tips increases, the stability of the cane will increase. As I said, it provides unilateral support. It assists with balance to reduce the weight bearing in opposite leg. And it's prescribed to patients who have osteoarthritis, peripheral neuropathy, or stroke patients with hemiparesis. The second mobility aid is crutches. It's used to provide bilateral support. We have two types. This is the axillary crutches, and this is the forearm crutches. The axillary crutches associated with the high risk of brachial plexus injury, but it's usually recommended for older adults. The forearm crutches are more functional and allowing the use of hands. This is the forearm, and this is the axillary crutches. The third mobility aid is walker. This is the most common and the most famous one, the stationary or pickup walker. It's provide bilateral support, very stable, and allows non-weight bearing. It's used in hip fracture or in unilateral amputations before prosthesis. And also we have two-wheeled walker. The two-wheeled walker provide a smoother and faster gait for Parkinson's disease and those who have total joint replacement. The wheelchairs used by non-ambulatory patients with cognitive impairment, or those who have a spinal cord injury, or those who cannot use the other mobility aids. They cannot use the crutches or canes. They can use a wheelchair. And this wheelchair must be fitted according to the patient's body build, weight, disability, and the prognosis. We should do environmental modifications. Can have a major impact on older adults' ability to function independently or with the minimal assistance at home. So those environmental modifications include assistive devices, grab bars. This is the grab bars. Look to this one. This is the grab bars. Usually we put them near the toilet and in the shower. This is the grab bars. raised a toilet seat at the bathtub seats like this one, and use a long-handled brushes. Long-handled bath brushes like this brush. All of these modalities and modifications will help the older adults to function independently at home. So in a summary, many comorbidities that could delay rehabilitations can be managed or prevented. Successful rehabilitation required a comprehensive assessment, coordinated interprofessional care, and all of this to access a high-quality care. Mobility aids and adaptive devices and environmental modification will enhance the function and the quality of life of those patients. These are our references, and I finished. Thank you.
Thank you, Dr. Reem and Dr. Fatin, for that extensive and detailed presentation about the rehabilitation. I think this
Thank
is
you.
a good background knowledge for those of you who are pursuing surgery and specifically orthopedics and possibly sport medicine. So before we proceed to our next agenda, if you have any questions, you can unmute yourself or you can text in the chat box. But very good and extensive presentation. Thank you to both of you.
You're welcome, doctor. Thank you.
If you have any questions, you can still write your questions at the chat box before we proceed to the next agenda of the presentation today. If not, we will proceed to the third part, which is side-by-side bars presentation in Excel and Google Sheet. And it will be presented by Dr.Syeda Asna. I think you can start sharing your screen. There you go. Thank you.
Hello, Dr. Naod. Can you hear me?
Yes, we can hear you.
All right. So good afternoon, everyone. First of all, I would like to thank my fellow researchers for the wonderful presentation on polypharmacy and rehabilitation. My name is Dr. Syeda Asna, and I'll be presenting today on how to create side-by-side bar charts in Excel and Google Sheets. All right. So in this presentation, we are going to basically explore the importance, creation, and analysis of side-to-side bar charts, ensuring that you gain the skills which are needed for effective data visualization. So understanding bar charts. Bar charts are essential for visualizing categorical data. They allow for easy comparison between different categories. In this section, we will discuss the side-by-side bar chart and their application in various fields, emphasizing their role in data analysis. So why side-to-side charts? They are basically used for enhancing comparative analysis by placing categories side by side. This format allows for quick visual assessment of differences and trends across multiple data sets, making it a preferred choice for many analysts. So creating an Excel. To create a side-by-side bar chart in Excel, start by organizing your data in a table format. Select the data, navigate to the Insert tab, and choose the bar chart option. Customize your chart for clarity and impact. Creating in Google Sheets. In Google Sheets, the process is similar. Organize your data, select it, go to the Insert menu and choose Chart. And from there, you can make the desired additions. So customizing the charts, it is the key to effective data presentation. In both Excel and Google Sheets, you can modify the colors, the labels, and legends. These adjustments enhance the visual appeal and improve the interpretability of your charts. Analyzing data. Once your side-to-side bar charts are created, focus on data analysis, look for patterns, trends, and anomalies. Discuss the implications of your findings and how they relate to your overall research objectives. Practical applications. They are widely used in fields like education for our purpose. They assist in presenting survey results, sales data, and performance metrics, making them invaluable for decision making. So one of the common mistakes that we're supposed to avoid is overcrowding, using inconsistent scales, and neglecting to label axes. Awareness of these issues will enhance your chart's effectiveness. So conclusion, mastering this skill is crucial for effective data visualization. With this skill that you're going to learn now, you can present your data clearly, enabling informed decision-making in your professional endeavors. So these are the two references that I've added from the TGRF website. To be honest with you, the first reference is a bit more difficult to understand. If you can follow the practical demonstration that I'm going to do, it is going to be much easier for you. So I'll just share my screen in a bit. Can you see my screen, please?
Yes, we can see your screen.
All right. So this is a Google Sheet, and I have attached over here the data that I want to make a side-by-side bar chart of. So what is this data about? This data is about basically the monthly CPR certifications, which I'm going to compare between the year 2023 and 2024, right? So just following 3 simple steps for making the side-to-side bar charts. First one is copying the data that you need. Copy and paste it in the desired application that you're using, either the Google Sheet in this case or the Excel. Second is followed by, you can also, of course, change the title of the document. So let's just make it CPR. All right. So the next step is going to be insert, right? You're going to insert and you're going to choose a chart. So as you see, it has selected a line chart, but for the purpose of our presentation, we're going to stick to the side-by-side bar charts. This is a pretty good chart, but there's still a lot of modifications that I want in this chart. So firstly, it's a column chart. The data range is A1 to C7. That is about, it's talking about the columns and the rows. And so if you want to add any series to it, for example, in this, as you can see, there is 2023 and 2024 data. But if you also want to add a 2025 data, you can add over here. You can select add series and label it. Thereafter, you can also switch rows and columns. Now, this one looks a bit complicated and I do not want to do this. So I'm going to keep it as it was previously. And I'm fine with using row 1 as headers and column A as labels. I'm fine with that. Now let's customize it. So this is the third step, right? Firstly, we're going to go to the chart style. I'm fine with it. Do I want to add a background color to it? Okay. Do you want to add a border to it? All right. So we can also make it 3D. We can maximize it, but I'm happy with how it is for now. Now coming to the chart and axis. As much as I'm happy with the x-axis, that is the month, but I'm not happy with the y-axis. I want to add the label to it. So firstly, regarding the vertical axis, it's fine. Okay. So I'm choosing the vertical axis, right? All right. Sorry, the horizontal axis. I'm choosing the horizontal axis, and this is fine. I like how it says month, but I just want to make it a bit bold. I'm fine with the rest. Now coming to the vertical axis or the y-axis. Over here, I want to add a title. That is, I want to mention that these are the number of, so I have these. So these are the number of students. I want to mention that. As you can see, it is clearly shown over there. I want to make it bold. And yeah, that's pretty good. Then coming to the series, I'm fine with the series. I do not want to add anything else. Legends. So do I want to make it at the bottom? This looks good. Yeah, this looks good. All right. Then coming to the grid lines and ticks, I'm fine with this. Coming to the vertical axis, I want to show the axis line as well. Now, regarding the title of the bar graph itself, I do not like the title of it. I want it to be a bit more specific. So I'm going to make it monthly CPR certifications comparison. All right. I want it to be in the center. All right. So once you're done with this, you can select it. Here's your data. Here's your table. What you can do is you can click the three right dots at the right side. You can either download the chart as a image, as a PNG image or a PDF document. I don't know. I'm not sure about the scalable vector graphics, to be honest. Or else I can also copy the chart, or I can even delete the chart, right? So this is about the Google Sheets. Now I'll just delete it and I'll show you about the thing that I was mentioning was about overcrowding, right? So if you don't want to overcrowd the chart, you just want the data from March to June, right? So what I'm going to do is just select the ones that I want and again, do the same thing. That's it, right? So now we have a fewer, there's no overcrowding over here. We just have 4 months and this is also something that you can do. Now we'll delete this for now. Now moving on to the next one. Just going to hide the video panel. All right. So coming to the Excel, it's pretty similar, to be honest. You change the title if you want to. Right now, doing the same thing. We've copy pasted the data over here. Now we're going to use the insert tab, add the column. We're going to select the clustered column over here. And over here we have it. So you double click it. And on the right, you get the changes. So again, you can change the title as you want it to be. So just make it monthly CPR for now. And I want it to be bold, right? I'm fine with the x-axis. And vertical axis. So you can also add the minor grid lines as well. If you want it to be, for example, if you're presenting a poster and you really want to know the numbers of, certifications that were increasing in the comparative years, I think this can be a good thing that you can add the minor grid lines. And yeah, I think what I want to do is access title. So I want to add month over here. Make it bold. Just coming to the vertical axis. axis title. So what is this? This is the number of students. Right. So it's pretty similar. Similarly, you can again copy this, and paste it wherever you want to. For example, I'll just show you. So we have two for now. So it's as simple as that. So with this, I conclude my presentation. If you have any concerns, please let me know. Thank you so much, Dr. Naod. You can please take over from here.
Thank you, Dr.Syeda. That is actually a perfect demonstration of preparing bar charts in Excel and Google Sheet. I think this will be helpful for those who have a numerical data or who have a numerical finding, especially in research-based studies. So this will be like a perfect way of building your own bar chart. But if you feel that you don't want to go all through the hassle of making your own chart, sometimes Canva also have a good prepared format. Some of them cannot be copied and pasted to your paper. You have to pay a monthly premium. But the basic one, like graph, pie, charts, and other stuff are free. So if you feel that you want to prepare a personalized and super specific charts, I think this would be a good idea. But if you want like a basic one, you can also take some formats from Canva. If any of you have any questions, you can either write your question at the chat box or maybe unmute yourself and ask your question. Thank you, Dr.Syeda. So if we don't have any question, we can proceed to our last presentation, which is going to be by Dr. Asim about the Anova test. I think Dr. Asim, you can take over and start sharing your slides.
Thank you, Dr. Nadir. Can you hear me well?
Yes, we can hear you clearly.
Okay. I am Asim Isa. I graduated with MBBS from University of Bahri, and I did my internship training in Aswan University Hospital in Egypt. Today I am going to present the Anova test, and also I am going to present on behalf of my colleague that she helped me in developing this presentation, but unfortunately she cannot be with us here today. Okay, can you see my presentation?
Yes, we can see it.
Okay, today I am going to talk about Anova test. My objective for today is introduction to Anova, and then the purposes of Anova test, the types of Anova versus t-test, key assumption of Anova, and Anova process step by step, and then post hoc test and application of Anova. And finally, I will conclude with take-home messages. Okay, what is an Anova test? Anova test also, it is an abbreviation of the analysis of variance. It is a statistical method used to compare the means of three or more groups to determine if there is difference among the group. Means are statistically significant. So in Anova test, we need more than two groups to compare. And what is the mean basically mean? The mean, also known as the average, is a measure of the central tendency calculated by summing all the value in the data set and then dividing them by the total number. And what is a t-test? T-test is a test used to determine whether there is statistical significance.
Sorry to
Yes.
interfere, but can you make it full screen so that all the other participants also can see it?
Uh, okay.
And then click the full screen.
Is it visible in full screen now?
You can click the one at the bottom. So that will show the full screen to all the audience. If you want, I can share my screen and I can click whenever you finish with this of your slides.
Just guide me which you want to click.
It's okay. I will share it for you, and then I can click every slide for you.
Okay, no problem. Is it okay this way now? Hello?
Can everyone see my screen now?
Yes.
We can start now.
Okay. We just were talking about the t-test. The t-test used to determine whether there is a statistical significant differences between the means of the two groups. The difference between the ANOVA test and t-test is that in ANOVA test, we need more than two groups to compare, while in the t-test, we only can compare between two groups. There is two types of t-tests that are independent sample t-test and paired sample t-test. The independent sample t-test compares means between two independent groups. Example for that is comparing test score of the two different classes. While the paired sample t-test compares means from the same group at different type. So it is the same class, but we compare the means at the two different times. Example for that also can be a comparison in treatment before and after treatment. Okay, next slide. What are the purpose of ANOVA? The purpose of ANOVA first is to comparison of mean. ANOVA test the hypothesis that different groups have the same mean. It helps identify if there are statistically significant differences among the group means. An example for that in a telegeriatric study, ANOVA can compare the effectiveness of the different rehabilitation methods in improving the quality of life for elderly patients. The second purpose of ANOVA is handling more than two groups. So why we just conduct multiple tests instead of ANOVA? Performing multiple t-tests increase the probability of making a type 1 error, which is considered a false positive error. So we control for this by evaluating all groups simultaneously, thus maintaining the overall error-free rate. An example for that, instead of conducting multiple t-tests to compare each pair of telerehabilitation method, ANOVA evaluate all methods together, reduce the risk of the incorrect conclusions. The other purpose of ANOVA test is to understanding the variability. Through ANOVA test, we can understand the variability in between groups and within group variability. So, example for that, in a study comparing different diets on healthy outcome, ANOVA can show whether the differences in health improvement are due to diet themselves, which is a comparison between group variability, or the differences within the individual within each diet group that represents the within group variability. So we can compare the both between groups variability and the variability within the study of groups themselves. Okay, we have mainly 6 types of ANOVA. The first one is one-type ANOVA. One-type ANOVA is a statistical method used to compare the means of the 3 or more independent groups based on a single factor, which is the independent variable. It helps to determine if there are statistically significant differences among the group means. An example for one ANOVA test is in educational study. Researcher might use one ANOVA test to compare the average test score of the student taught using 3 different teaching methods, such as traditional lecture, online learning, and blended learning. This analysis helps identify which teaching method is most effective in improving the study outcome. This is an example of the one-way ANOVA test. On the vertical y-axis, this is the weight, and we want to compare the weight across the different 3 treatment groups, the control and treatment 1 and treatment 2. So if we want to control this weight across all the 3 different groups, we will use this ANOVA test to measure the variability within each group. So we notice through the means there is a variability in each study of the 3 studies. And this is an example of the simple t-test. As I mentioned, in t-test, we compare the variability between only 2 groups. This is an example in y-axis. We need to measure the expression of the certain gene called GAS5 in hepatocellular carcinoma in the healthy individuals that are represented by the blue, and in the patient with the primary tumor of the liver that are represented by red. The line that draw above them with the 4 star represents the significant level, while 4 stars indicate that there is a significant variation between the normal and primary tumor. This is, we can measure it using only t-test. The same here, if we want to compare 2 groups, our option will be the t-test. But if we have more than 2 groups, then we will go for one-way ANOVA test. Okay, the second type is two-way ANOVA. Two-way ANOVA examines the influences of the 2 different independent variables on a dependent variable and can assess the interaction between these 2 factors. It is used to understand both the main effect of each factor and their interaction factor. In the one-way ANOVA test, we measure an independent variable against only one dependent we measure one dependent variable with the 2 dependent variable. While here in the two-way ANOVA, we usually use 2 different independent variables on a dependent variable, so we can know the effects in the studied group and also the interaction of the factor between each other. An example of that in a health study, researcher might use two-way ANOVA to investigate how diet, such as diets that contain low fat and high fat, and exercise, regular and occasional exercise, affect the weight loss. This analysis helps to determine not only the individual effect of diet and exercise on weight loss, but also we know how these factors interact with each other. The third one is the repeated measure ANOVA test. Repeated measure ANOVA is used when same subjects are measured multiple times under different conditions. It accounts for individual variability by comparing the means of the sample group at different time or under different conditions. So here we measure the variability in the same subject, but over different period of times. An example for that, in a clinical trial, the researcher might use repeated measure ANOVA to measure the performance of the patient before, during, and after a new treatment. This analysis helps assess change over the time while accounting for the fact that the same individual are being tested repeatedly. So we measure the change over the time in the same treatment groups. This is an example of the repeated measure ANOVA test. The blue lines indicate the control group, while the red line indicates the treatment group. Over the change, we can notice here the change over the time from the baseline and injection. Almost the two groups, the control and treatment, the same, but we now notice the variability after 1 hour, which is more significant in the treatment group represented by the red line. So here we measure the variability in the same group, but over different period of time. The fourth type is a mixed design ANOVA. This is combines both between subject and within subject factor. This type of ANOVA is used when researchers want to examine the effect of different treatment over the time. So here we want to measure the effect between two treatment subjects and within the same group of the treatment. So between subject and within subjects themselves. An example of that in a clinical trial, researcher might use a mixed design ANOVA to test the effectiveness of different treatment, for example, drug A and drug B, on a patient outcome measure at multiple time points, at the baseline, at the 1 month, and at the 3 months. So allows for analysis of both the treatment effect and the change over time within the same subject. As you can see, if we consider the green graph is the drug A, while the pink is the B, and blue is the C. So here in the mixed ANOVA, first we measure the variability between the three groups together, and then we measure the variation within each groups themselves inside. The fifth type is called multivariate ANOVA or MANOVA. This is an extension of ANOVA to situation where there are two or more dependent variables. MANOVA assesses the impact of an independent variable on multiple dependent variables simultaneously. And what we mean by dependent variable is actually the variable or the outcome we want to measure, while the independent variable are the categories or the categories that we want to measure its effects on the dependent variable. For example, in an educational study, researcher might use MANOVA to assess the impact of training program on both performances and satisfaction. So we have here two desired outcome or dependent variable, which is the performances and the satisfaction. This is allow for comprehensive analysis of how the training program affect multiple outcomes at the same times. As we said, the level of education, which is our independent variable here. So if we can measure the life satisfaction and the job satisfaction. If we measure only one independent variable against one dependent variable, this is called univariate ANOVA. The last type is called analysis of covariance or ANCOVA. It is a statistical technique that combines ANOVA and regression. It is used to compare one or more means while controlling for the effect of one or more continuous variable, which we will call them covariate. The regression is a different statistical method used to understand the relationship between one dependent variable and one or more independent variables. It helps in predicting the value of the dependent variable based on the values of the independent variable. So if we want to conduct and cover this, we have three key components. We have to have dependent variables, which is the outcome we want to measure, the independent variable or variables, which are the categorical variables that we are comparing. An example that's the treatment groups of a specific drug, for example. And then the covariates, which are the continuous variables that we want to control. An example for that, such as the age or baseline measurement. An example for Anova test, suppose you want to compare the effectiveness of the three diets on a weight loss while controlling for initial weight. Here, the weight loss is our dependent variable that the outcome we want to actually measure, while the different type of the diet are independent variable, and the initial weight is the covariate that we want to control across all the treatment groups. So Anova test is lie in the middle between the Anova and regression tests. This is an example of the statistical software we can use to conduct the measurement of different type of ANOVA, such as the R programming language, the Python programming language, and statistical package for social science, SBS. We have also statistical analysis system, Stata, statistical software, and matrix laboratory, and Excel Microsoft. Each one of them use it in the specific situation according to the specific field. So what is the differences between ANOVA and t-test? Here in this table, we will summarize the main differences between ANOVA and the t-test. ANOVA, regarding its purpose, it compares means across three or more groups, while t-test compares the means only between two groups. ANOVA has mainly three types, the one-way, two-way, and repeated measure ANOVA. The other three types actually consider an advanced way of ANOVA test. While the t-test have two types, which is independent t-test and pair t-test. Regarding the null hypothesis, ANOVA assume all group means are equal, while t-test assume the means of the two groups that you are measuring are also equal. But the differences here is only two groups, and there is more than two groups. ANOVA test requires three or more groups of data, while t-test require two groups of data. ANOVA test assumption, this is we will going to talk in the next few slides. It depends on, you have to have assumption which are the independence. You must have an independent variable, normality, which will mean that the data must be normally distributed, and you must have a homogeneity of variance. That means the variance you are studying are actually similar or close similar to each other. While in the t-test, the assumption you only need that you need to have the independency of variable, and the variable should be normally distributed for each group. The output of the analysis in ANOVA we conducted according to F statistic and compare it with the p-value. While the t-test, we conduct the t statistic and compare it with the p-value. Regarding the post hoc analysis, which is the analysis that you conduct after your initial experiment or study is in, you conduct the post hoc analysis to compare the specific differences that you are noticed in your studies. So ANOVA tests usually require post hoc tests if you have found a significant result from your initial analysis of your collected data. While t-test doesn't have doesn't need post hoc test. ANOVA test used in experiment with multiple treatment, while t-test used in experiment comparing only two conditions. An example for each one of them, ANOVA comparing test score of students from three different teaching methods, while t-test comparing test score of students from two different teaching methods. Okay, let's talk about the key assumption of ANOVA. First, the independence. The observation within each group must be independent of each other. This means that the outcome of one subject should not influence the outcome of another subject within the same group. So when violating this assumption can lead to misleading results, as the statistical test assumes that each observation is an independent data. The second key assumption of ANOVA is normality. The data in each group should be approximately normally distributed. This is assumption ensures that the statistical tests used in ANOVA are valid. While ANOVA is fairly robust to violation of normality, significant deviation can impact the accuracy of the result. Ensuring normality helps maintain the reliability of the conclusion drawn from the analysis. We can have variables that not entirely normally distributed, but in this case, you need to ensure your sample size is well enough to compensate for this. The third key assumption is the homogeneity of variance. The variances among the group should be roughly equal. This means that the spread or dispersion of scores should be similar across all groups being compared. If this assumption is violated, it may affect the reliability of ANOVA result, particularly when the sample size are unequal. Homogeneity of variance ensures that the comparison of group means is fairly and unbiased. So in order to conduct another test, you need to ensure that you have this three key assumption of independence and normality of the data and the homogeneity of variances. How to check for this assumption of ANOVA? We have several methods to check for this assumption. For example, Levene test can check for the homogeneity of variances. Levene test is used to assess whether the variances among the groups are equal. So conduct the test by comparing the variances of the groups. A non-significant result, which is when the p-value is more than 0.05, indicates that the variances are equal, stratifying that the assumption of homogeneity. So you conduct Levene test to ensure that the variance between the group are equal and there is no significant result, and so that it is more than the p-value. Other tests we can do is the Q plot for checking the normality. It's also called quantile plots, which are graphical tool used to assess whether the data follow a normal distribution. Plot the quantile of the data against the quantile of the normal distribution. If the points lie approximately along a straight line, the data is considered to be normally distributed. Now we're going to talk about the ANOVA process step by step. You will start by formulating hypothesis. You will formulate first the null hypothesis, which states that all group means are equal. For example, in a study comparing the effectiveness of three different teaching methods, the null hypothesis would state that the mean test score for all three methods are equal. There is no difference between their means. Then we will state another alternative hypothesis. At least one group mean is different. An example for that, the alternative hypothesis will state that at least one teaching method lead to a different mean tested score comparing to others. So you have to formulate first two hypotheses, a null hypothesis and then an alternative hypothesis to your null hypothesis. Secondly, we calculated the F statistic. And what we mean by the F statistic? The F statistic is the ratio of variance between group means to the variance within groups. Between group means measures the variability due to interaction between the groups, while within group variance measures the variability within each groups. So the formula will be for F statistic that between group variance over the within group variance. The interpretation of this accordingly, if you have a higher F value, this indicates a greater likelihood that the observed differences among the means are statistically significant. We compare the value of the F statistic to the B value. So if this value is significant, it would be less than the B value, which is less than 0.05. Then we will determine the p-value. The p-value is the probability of obtaining an F statistic at least as extreme as the one calculated, assuming the null hypothesis is true. Compare the F statistic to critical value from the F distribution based on the quotient significant level. Usually, we consider the value of the p-value 0.05. If the p-value is less than the significant level, reject the null hypothesis. So you will proceed with your alternative hypothesis. The fourth step is interpretation of result. Either you rejected the null hypothesis. If the p-value is less than the significant level, it indicates there is a statistically significant difference among the group means, which is less than 0.05. So, for example, in teaching method study, rejecting the null hypothesis would suggest that at least one teaching method leads to a significantly different mean test score. Failing to reject the null hypothesis in case if the p-value is greater than the significance level, it indicates that there is no statistically significant difference among the group, which will confirm your null hypothesis. Then, after we measure the significant levels using Anova test, we will conduct post-hoc tests. What are the post-hoc tests? Post-hoc tests are the statistical analysis conducted after an Anova to determine which specific group means are significantly different from each other. They are necessary when the ANOVA indicates that there are significant differences among the group, but does not specify where those differences lie. So we conduct the post hoc test to know more details about the level of significance between the two significant groups. We can use multiple tests such as QKHSD, honestly significant difference. The purpose of this test is used for pairwise comparison to determine which specific group means are significantly different from each other. After finding a significant result with ANOVA, 2PHSD helps identify which pair of groups differ. So if you have a significant levels between two groups, you will conduct this test to know which one of those two groups are much more significant. Example, in a study with a 4 treatment groups, TUKHSD can pinpoint which specific treatment have significantly different effects. The second post-hoc test we can use is called Polypharmacy correction. The purpose of it is to adjust the significance level to account for multiple comparison, reducing the risk of the type 1 error, which is the false positives. Useful when conducting multiple pairwise comparison to ensure the overall error rate is controlled. So, for example, if comparing multiple diets effect on weight loss, Polypharmacy correction ensures that the significant level is adjusted to maintain the integrity of the result. So we use this test mainly in case we are measuring multiple comparison groups. A scenario if ANOVA show a significant differences in means among 4 treatment groups, consider A, B, C, and D. Post-hoc tests like UPHSD and Polypharmacy correction can be used to identify which specific pairs of group, for example, A versus B or A versus C, have a significant differences. So in summary, in the step of the hypothesis testing, after you collected your data, you state your hypothesis, you state your null hypothesis and your alternative hypothesis, then select the test statistic. In this case, we have the ANOVA test. Then we calculate the test statistic and then come into a final statistical decision. Either you reject the null hypothesis, which concludes that your alternative hypothesis is true, or either you fail to reject your null hypothesis and conclude that your null hypothesis is true. Now we are going to talk about the application of ANOVA. ANOVA is applied in multiple disciplines, such as psychology. ANOVA is used to compare the effectiveness of different psychological treatment or intervention. For example, researchers might use ANOVA to compare the mean reduction in depression scores among patients receiving cognitive behavioral therapy, psychoanalysis, and medication. By analyzing the variance in depression score across these groups, researchers can determine if one treatment is significantly more effective than other in reducing the depression. Also, it can be used in biomedical science, such as when we use to compare the levels of gene expression of certain gene across different conditions or treatment to identify significant differences. For example, medical researchers might use ANOVA to compare the expression level of specific gene in cancer cells treated with different drugs. This is help determine which drug most effectively alters the gene expression. We can also apply it in the agricultural science. ANOVA is commonly used in agricultural research to compare the effectiveness of different farming practices, fertilizers, or crop varieties. For example, an agricultural study might use ANOVA to compare the mean crop yields from the field treated with three different types of fertilizers. This helps determine which fertilizer leads to the highest yield. Also, we can use it in marketing. In marketing, ANOVA is used to compare the effectiveness of different marketing strategies or to analyze the consumer preferences. For example, in company might use ANOVA to compare the mean sales generated by three different marketing companies, such as social media ads, email marketing, or TV commercials. This is help identify which campaign is most effective in driving the sale for that specific company. Next, please. Okay, finally, we are give just some more example and application of ANOVA in medical research. As we talked before, we use ANOVA to compare treatment effect. Example is this in clinical trial comparing the effectiveness of three different drugs on the blood pressure reduction. Researcher can use one-way ANOVA to determine if there are significant difference in mean blood pressure reduction across the groups receiving each drug. This is mainly used here in clinical trials. Also can be used in evaluating patient outcome. For example, researchers might assess the impact of different rehabilitation programs on the recovery times after surgery. A two-way ANOVA can help evaluate the effectiveness of both types of rehabilitation program and patient age on recovery times. While we can use it also in assessing the variability in biomarker in study investigation the level of particular biomarker, let's say it's cholesterol level across different population or age group, ANOVA can identify significant differences in means, helping to understand how factors like age or lifestyle affect the biomarker levels. Also, we can apply it in studying the risk factor. For example, researchers might explore how different lifestyle factors such as the diet or the exercise level affect the incidence of conditions like diabetes. Another can compare mean glucose level across groups classified by these lifestyle factors. And lastly, on longitudinal studies, for example, in repeated measure studies, such as evaluating the effectiveness of drug over multiple time points in the baseline and after 1 month and after 3 months, a repeated measure ANOVA can help here assess whether there are a significant change in the outcome over the time and between the treatment group. So the take-home message for today is that the ANOVA is mainly used to compare the mean of the three or more groups to identify the statistical significant differences. And there is mainly three types, which is the one-way ANOVA that compares means based on one factor only, and two-way ANOVA that examine the influence of two factors and their interaction with each other, and repeated measure ANOVA that use it when same subject are measured multiple times under different conditions or over different time periods. Uh, We also have to consider the key assumption when we conduct the Anova test, which is to maintain the independence and the normality and the homogeneity of variance. And the steps of the ANOVA process that start by collecting your data, then formulating your hypothesis, calculate your F statistic, and then determine the p-value and compare the F statistic to the p-value and interpret your result. Lastly, if applicable, if you want to do additional statistics to know specific differences between the significant result you have obtained, you can conduct post hoc tests such as TUK HSD test for pairwise comparison or Bonferroni correction that for multiple comparison. So this is the end of my slide, and thank you. If you have any question, feel free to ask.
Thank you, Dr. Asim, for the extensive presentation about the Anova test. We would like to also thank Dr. Alaa for making the slides and presentation. If you have any question, you
Thank
can
you.
unmute yourself and chat it in the box. If not, we will proceed to the last part of our today's agenda. If no one have a question, I just want to thank all the presenters from Gold Team and from the other team who joined today to present and help in participation of this session. I just prepared two short presentation. One is 2 slide and one is 7 slide presentation, just to give an idea to those people who are seeking application or people who actively want to participate in research. So this will give you like a framework of what to do, what not to do, how to start a paper, and at the same time, I will also try to address some of the repeated questions which has been asked in the group. Give me 1 second. Can you see my screen? Can you see my screen?
Yes, we do.
Okay, so today we'll discuss like basic concept of research, and we will also try to address of some of the repeated questions from the follow. So this is like most of the questions which are repeated from most of the group members. Number one question is, how do I join this fellowship? Number two question is how to join a group research. The third one is how to make a presentation. And the fourth one is how to find additional material regarding residence application and other conferences. And the fifth and the most important one is how to publish a research paper. And the last one is about a conference. So regarding how to join to this program, it all starts with a confirmatory email from Dr. Nadir. So once you have that confirmatory email, you have officially joined the group. If you are good with electronics, you can download the Telegeratic Research Fellowship app in your phone and in your laptop, so that all the access will be free for you. And the Saturday meeting, you can join via Zoom, which is free. And you are also advised to actively participate in most of the presentation. And the second question is how to join a group or research. I think Dr. Nadir have formed a colored team setting. So depending on the color, you will be assigned to a specific group and you will be joining that group to do a research. If you have a problem finding your team colors, after this presentation, I will show you the simple way of finding your name and the team that you are assigned to. And I think Dr. Sarah Mohammed made a good job of forming the WhatsApp group for different colors. So the first thing is you identify to which color you are assigned, then you find your team, then you join. Or you can also join other teams, especially if you have a special interest in a specific paper, or if you feel that that Saturday session presentation would be better explained or presented by you. For example, if that topic is psychiatry or pediatric surgery or something which is not common to most of us, then you can reach out to the other teams and offer your help to present. Because I think if you have someone who is specialized in specific field, that would be a good way of enhancing your knowledge, and also it will be a good way of us learning from people who are expert into that field. There is a WhatsApp setting which was created by Dr. Sarah. You can join that WhatsApp group, and from that WhatsApp group, you can proceed joining the different colored teams, and you can also write whatever concern you have about a research project or a presentation or a session. And if you find your friends from different setting or from high school or from medical school or from a different observership, sometimes you can also make individual group within the frame of this fellowship. And if you have a specific preference to a specific team, you can also ask them to join. We would always advise to make the group like less than 25 so that it will be more effective, and the workload would be like equally distributed among all of the fellows. And the next question is how to make presentations. So Dr. Nadir have created a queue depending on the color of the presenter. So depending on your color team, you have an assigned assignment to present throughout the year until March next year. So all you have to do is identify your color team, join that group, reach out to your team leader, then find out in the queue which date of the month you will be presenting. Sometimes there can be also cross-sharing with groups depending on your preference or on your comfort level. You can also create sometimes individual setting or group depending on your preferences. Additional materials after the PowerPoint presentation is over, I will try to show you how to find them. And this is the core part of this presentation today, how to do research or how to pursue publication. First, you have to set a team or be part of a team. This is the first part. So depending on your preference of specialty, whether it's internal medicine, emergency medicine, family medicine, or psychiatry, you can set up a team who have a good understanding of what they want to do, pursue a research publication into that field. And the second one is you have to choose what paper are you trying to prepare. Are you trying to prepare a systematic review? Are you trying to prepare a meta-analysis or case report or cross-sectional? So this depends on your knowledge level and the data you have. For example, if you are actively working in a clinic, you might find a specific case which is very interesting, and that's worth of a paper. So those people who are actively in practice, if they find a special case, they can prepare it as a case report. And if you work in a research center or if you have access to a huge chunk of data, you can also do cross-sectional study. And if you are more of like an analytical person, you can also do meta-analysis, and systematic review might be the base one or start of someone who doesn't have a previous history of publication. But remember, when you set up a team, the fact that you set up the team doesn't automatically make you a team leader. What I would advise and what I have done over a period of time is just, if you are a new starter to research, start with the easiest task that's allotted to you. The easiest task would be making the reference. Making reference doesn't involve that much of a hassle, and it's the easiest part. But while doing so, try to learn from the team leader, try to learn from people who are doing the discussion, result, meta-analysis, or graphics, or poster, or abstract preparation. So over a period of maybe 2 to 3 months, then you can jump yourself up and be confident to be part of a group or part of the topic who is able to be making the result or the discussion, which is the main part of the paper. Then after that, you can be a second author or co-author, or maybe you will be the submitting author of that paper. Then you slowly build up that cadence or that flow of knowing what to do and what not to do. So when you join a group, if you have no idea how to run a group, and if you have no idea previous history of publication, it's better to join a group who are currently well aware of all the requirements to publish a paper. While you join with that team, try to learn a lot, and with self, you can self-promote yourself and be the co-author or the co-writer or maybe the first team leader. So while joining a team, probably the team leader or maybe the first 4 or 5 authors will choose a journal or conference to present or to submit that paper. There are a lot of factors that you should consider. One is impact factor. Impact factor is just a numerical way of equating how important your paper is. Some journals have high impact factor. For example, New England Medical Journal is the well-established, big journal. So those journals have a big impact factor. Unfortunately, the bigger the impact factor a journal have, the bigger the rejection is because their data is bulletproof. They have to submit everything A from to Z, and it should be error-free. So as a starter, you should always start with journal who have a mid-title or like a little bit smaller impact factor. So the proceeding that you go submit into that paper will give you the background knowledge of what to do and what not to do when you kind of self-improve and start to promote yourself in publishing in the more respectable journals. Timeline is important. I don't want you to join a group at the end of June or May in the hoping that your name will be in ERAS application. I always advise people to start research project in the middle of September or October. Well, they will have about 6 to 8 months to have at least 4 or 5 publications. So even though this might depend on your personal preferences, I think joining a group at the end of the year would automatically mean that you just want yourself to be included in that paper. So if you are seriously seeking publication, start in the middle of October or November. We will have a chunk of time to go over all over the data. Cost is also important. Some journals, they cost you a lot. Some journals are for free. Some journals, they require you to be part of their institution so that they will give you a discount cost for publication. Reputation of the journal also matters. Some of the journals, they don't even check your spelling, to be honest. That means that you will automatically get a publication, but the impact factor may be 0.1 or 0.5, which is not worth it, by the way. And the fact that your paper got rejected doesn't necessarily mean that the game is over. When they reject it, most of them, they give you a reason. If it's an automatic rejection, you most likely didn't work on the paper. If they ask you a major revision, probably you know what you are doing, but you are not there yet. If they give you a minor revision, probably you made some grammatical error or data error. Always set a timeline, whether you are a team leader or team participant, set a time where the paper will be starting, when the data will be collected, and when the data will be submitted for publication. Always try to be proactive. Just don't throw your name at a project and disappear for 3 months. Just try to be proactive, especially if you have an access to an internet or WhatsApp. It only takes about 5 to 10 minutes to reply to a group leader or an active participant of your group member. So try to be proactive and do what you can so that the paper will be done. Always check plagiarism, content, spelling, or format type before submitting a paper. So most of the time, if you get an automatic rejection, most likely you copy pasted your paper from other people and they will immediately reject your paper. The computer will not even let you pass that first line of filtering. So there are a bunch of different programs that will help you check the plagiarism content Grammarly. I usually use Quitex, and most journalists, they prefer you to only copy about 17 to 19, maybe 20% of from the already published paper. So always check the plagiarism. Then you can submit after that. 3 points: start early, be a fast learner. You might be a group leader in one group, the next group or the next project, you might be the last author. It doesn't matter as long as you learn something out of that project. And remember, what we are doing is free, which is good. Most other people or other institution, they cost you money or they ask you for money to just have a simple publication. So always make use of this platform. Conferences, they follow the same principle as abstract submission and research paper. The only difference is just you have to make a poster of your abstract. The only difference here is in terms of the formatting. They will have their own guidelines in terms of the size of the poster, the word count, the amount of pictures and graphs that are going to be included. And other specific details which are required from the journal. Conferences is a good way to network. It's not a place to kind of shiny work. The poster presentation usually take about maybe maximum 1 hour, 1 hour and a half. So this is a place to network, to ask people about their business card, where they are from, which university, which residency program. This is a very good place to network. So I hope I have explained it, especially for the new follows who were not 100% sure about how to proceed and how to kind of navigate their way in this fellowship. If you have any questions, I have created a Loom video before a year. I will try to share it in the chat group, and I will also show you some. So this is what you find when you immediately click the Telegeriatric Search Fellowship app. In this side, you have the senior fellow, junior fellow, senior fellows, the junior fellows, the dentists, the team leaders. So supposedly we have Dr. Fatin today. So I will write Dr. Fatin. So when you are assigned to a program, when you submit your paper, your name will be there. So the best way to navigate yourself is click your name. You'll have your network, your name, your email, and then you will have the color of your team. So supposedly if Dr. Fatin was not aware which color she was assigned to, the first thing she will do is she found her name. She's assigned to a gold team, and she will find all the team members here. And she will immediately or with time contact whoever she feels comfortable. Because this is a new season, some of us might match, some of us might not match, and some of us might have matched already. It's a good way of being proactive and giving back to the team. So always, if you have already matched, you can always assign a new team leader so that the project will go on, but at the same time on the background, you can be a mentor and helping other people do publication. When you go down at the home section, this is the new rebranded one. So you'll find all the previous publication from this group. So let's say Mr. X or Mr. Y want to do a poster presentation. So instead of waiting 1 week or 2 weeks to get a response from the main WhatsApp group, which might contain about 300 or 400 people, you can go to your conferences and you can find Dr.Syeda here, for example. So if you wanted to ask about the fees, the traveling costs, what did you do, how you did prepare the paper, you will find the people who have already done that task. So this is like a quick way of reaching out to people in order to resolve your problems or solve whatever question you have. Give me 1 second. And the active projects are here. So if you feel that you are a good team leader, or you can proceed by choosing one topic for presentation, you just can pick one paper from here and start a project. So what I would advise is just try to play around with this app when you are free, or when you are traveling, or when you are at the gym, or whatever time you feel that you are doing. You can always play around with this app and see what's in there, what kind of resources are here, what kind of publication opportunities are there, what kind of free certificates are there. So you can do this one. And regarding for those people who have already submitted a paper, are you following me? Sorry, I'm just talking. Is
Yes.
everybody hearing me?
Yes.
Yes.
So let's say you have already prepared your paper and you just want to submit it to a journal. So after working 6 to 8 weeks, if you don't check your paper is spelling wise correct and you haven't copied anything, then it's a waste of time, because usually journals, they respond within 4 to 6 weeks. So if I have already submitted a wrongly prepared paper, you have already wasted about 6 weeks without doing nothing. So let's choose one paper that I was a part, for example. Let's say someone copies this and use it as a direct reference in their paper. So they have used this one as a direct reference in their paper. Let's see how much the plagiarism content is. So supposedly someone have quoted this part of their research word for word. It says that I have 100% copied from one research paper. So when your paper is ready, you can put it here and make sure the percentile is less than 15 to be safe. So that when you submit a paper, you know for a fact that in terms of plagiarism, spelling, format, you are free of error. The rest comes to content. That will give you that passage to the first filter of the journal. And if you have any questions, you are more than welcome to ask before we go to the last part of one slide presentation for about interview.
Good morning, everyone. I have a question.
Go ahead.
If I have a research idea, where can I find the data source, or how am I able to get the data from? From where?
So as you can see from that slide I prepared, you have to make a choice whether what kind of paper you are preparing. If it's a systematic review, it's a bit easy because you are trying to review what have already been published. But if it's a case report, the data is from your hospital. If it's a cross-sectional, it's probably from a data institution. If it's a meta-analysis, it's a bit of a mix of both of them. So if you are preparing systematic review, it's a bit easy. You set up your team, especially if you have a history of publication or if you have a good knowledge of how to become a team leader. You can take the task, assign the task, and kind of navigate everyone and teach them what to do, what not to do. It all starts with choosing what kind of paper you want to prepare, the title of the paper also. And that's why from the app, there are already prepared titles, which means those titles, there has not been that much of a research done before. So choose a title, choose the type of paper, what kind of paper are you going to present, and at last, set up your team. Always analyze and prepare your paper in a such a way that you will not lose another maybe 2 or 3 months. So just to sum it up your question, the data depends on what kind of paper you have decided to do. I hope I answered your question.
Yeah, thank you very much. Thank you.
And I see one person texting. The website name Quitex for plagiarism is free. The first 1,000 or 2,000 words, they are free. Then it's about $10 or maybe $12 for a month. Any other question?
Yeah, I have one.
Go ahead.
I want to ask on how to become a group leader.
Honestly, I cannot give you the specific answer, but if you communicate well, if you have a way of getting along with everyone, and if you are good at making a framework of what you want to do, like to implement your ideas into one big project, you can assign yourself your team leader. The problem is if you don't know how to assign tasks or if you don't know how to analyze tasks, because as part of a team leader, your job is when the individual members are done with their respected projects, you will be the one compiling and having a good look at the whole paper. Then if you don't know, or if you have not been a team leader before, then you probably are not going to know what's wrong or what's right. And the only way that you can find out or that you can learn from that is just be a team member first. Be the least contributing person of a team member first, but don't miss any meetings or sessions about a paper, so that with time you will develop that attenuation of what to do and what not to do.
Okay, thank you.
If you don't have any questions, we can proceed to the last part of the presentation. But if you have any question, you are more than welcome to ask.
I have a question, doctor.
Go ahead.
Okay. First, thank you for the very informative session. My question is about how to access the WhatsApp group.
The WhatsApp group?
Yes.
I will try to send you the link after the session.
Okay, thank you so much, doctor.
You're welcome.
Hi, Dr. Nader. I have a question.
Dr. Nadir, are you here?
Hello?
Is the question for Dr. Nadir or for me?
Oh, it's for you. I'm sorry. I
Okay.
apologize. My question is, if I want to publish a case report, for example, you mentioned that there are no fees or there are fees. I didn't catch that part.
So it depends on the journal that you are submitting for. Nowadays, I think before 2 or 3 months, maybe one of the group members in WhatsApp have posted a list of journals with 0 publication fee. I think if you find that, that would be helpful. So there are journals with 0 publication fee. They might not be as, their reputation might not be as good as what we want, but for a starter, I wouldn't mind taking them. You will learn on the way of what to do and what not to do. So I'll try to find out that and I'll try to send you.
Thank you very much.
You're welcome. Any other question to me or to the other presenters before we proceed to the last part of today's session? I know we are supposed to have a mock session for interview. Unfortunately, some of the team members, they live in a different time zone, so we couldn't do the mock session interview. But can you see my screen?
Yes.
We can.
Okay, just have a few points. So for residency interview, what I would try to focus would be, one is present what you presented, which is if you have submitted, let's say, a 5-page ERAS application to a specific program, the whole concept of having an interview with just the interviewer wants to know whatever you have wrote on that paper is you. So know your way out. Try to remember all the data that you have put in there, your experiences, whether it's observership, clinical attachment, publication, or volunteering, whatever you have put there, you should know it, one. And second is try to communicate well. Communication is really key in a semi-professional way. Don't be rigid, but at the same time, try to answer it like in a more professional way. Stop using this slang language. And always don't rush to answer a yes or no question. Try to analyze, or maybe just try to have a way of navigating a good answer to that question. Because yes or no questions sometimes may be blocking questions. If you say yes, or if you say no, then you have nothing to say. If you feel that your vocabulary is a bit poor, try to be straight and don't overdo things. Try to assess the question and answer it in a very simple English. Setting of audio and video, especially for the virtual interviews, very, very important also. Don't oversell yourself, but don't be shy of also from highlighting your achievements. Let's say if you have one publication from Curious, and if the interview is 45 minutes, and if you speak about that publication only for about 15 minutes, you are not utilizing your time of the interview wisely. So if you feel that you have some achievement that rarely can be done by a regular applicant, try to shine and try to talk about it. But if you have like a mid-level achievement, then try to focus on your personality traits rather than your achievements. Sometimes expect the unexpected, because questions that were not on your head may come up. So that's why I always advocate for mock interview to be close it, which means you give your application to the one who is going to interview and you don't know the question. If you know the question, things are easy. So the best way to master a way of responding to a question is if you don't know the question. So your friends or someone who's an English speaking individual, give them your CV and direct them on the objective of the interview. Then they will come up with questions that you are not prepared. If you do a mock interview, just hand them your CV and the questions should not be known by you. That would be a great way of training yourself how to respond to questions. Sometimes you have to be at ease, don't be rigid, and do your homework. What this means is just know the program inside out. You have to know the program, whether they offer fellowship, the culture diversity, extracurricular activity, everything, know the program. That's a way of telling to the program director that you are interested in the program. Always give explanation, not excuses. If you are a 2005 or 2010 graduate and you haven't touched a patient in 10 years, don't give excuses. Give explanation, the reason why you didn't do so. If you have a low score or multiple attempts or no publication or visa issue or something that might be of a red flag, try to formulate an answer that would seem an explanation rather than an excuse. Always show resilience, be a team player, show professionalism, especially for those of you who are applying to emergency medicine, psychiatry, or plus or minus gynae, especially emergency. You spend most of the time with the nurses, doctors. So when they interview, they unconsciously analyze whether you will be a kind of person that they want to hang out with for a 12-hour shift or 16 or 18-hour shift. So project the idea that you are a team player, easygoing, and you can blend in different case scenarios, and always also show professionalism. And this is what I have for today. Thank you everyone for following the presentation today. If you have any question, comment, let me know. If not, if anyone have an update on new project or pending project or any project that has been accepted recently, I think Dr. Nadi is here also. You can take over and unmute yourself.
Thank you so much, Dr. Naod. Thank you, everyone. Thank you, the presenters, and this is great. I think one of the fellows presented a poster last week. So congratulations on that. I'm not sure if she is here today. Any other updates? If not, I'd like to thank you so much, Dr. Naod, for entering this session and taking care of the team, and a great presentation, all of you.
Assalamu alaikum, Dr. Nadir.
Alaikum salam wa rahmatullah, Dr.Syeda. Here we go.
How are you doing, sir?
I'm doing great. Thank you. Congratulations.
Thank you, sir. I mean, it's only with your guidance that I was able to do the presentation. I really thank you for your time and effort in reviewing it in the short time.
Thank you. How was experience for you? Is this your first poster or you had posters in the past?
I mean, at this level, yes, sir. This is my first poster, and my topic was about resuscitation agility and how we're going to innovate emergency cardiac care protocols in response to mpox and other similar infectious diseases. So as much as I was prepared about answering for mpox, I think because now we've added, now we represent research fellows, I think they asked me the definition of a narrative review. And I was really taken by surprise. I mean, as much as I did answer her, but I wasn't, she didn't look very convinced. And you expect a different language when you're speaking to a research fellow. You don't want a language which is, the one that is we use commonly. So I think that is one thing that I would like to advise all my fellow researchers as well, is when you're doing any studies, to know the definitions as well of what kind. And she even asked me the difference between the systematic review and a meta-analysis and all of that. And I did give her the answer, but again, it was not to the point. And but I'm grateful. I'm so grateful that I got the opportunity in the first place, and I really thank you, sir. I mean, you were the only mentor who was missing in the conference, and thank you so much. Thank you.
You're welcome. Congratulations. And remember, all these judges are there to judge who did the best and so forth, because some of the conference, they have their prizes. And but for you, I think you did great, and congratulations. So
thank you, sir.
That's the way.
Thank you so much.
Any other updates? If not, leave it back. I'll give it back to Dr. Naod. Please go ahead.
I thank you, Dr. Nadir, first of all, for giving me this opportunity. I also would like to give a friendly reminder to all the team leaders who haven't accepted the request of the fellows who wanted to join the group. When you can, just please spare 5 or 10 minutes to accept the fellows who want to join your group, so that the WhatsApp chat would be more focused on how to apply to residency, how to prepare research, how to have resources easily at a zero cost. So that would be like more concentrated on the final goal. So all the team leaders, please be helpful. All of them are helpful, but sometimes you might be busy or taking step 3 or family or kids. So that will make the conversation really easy and the flow would be good. And as always, we all been there, because when I started this project, I have no clue of what to do research. It's just a learning process. So those people who are just starting from scratch, you will see yourself in 6 or 8 months, a completely different individual. So that will be a starting point. Don't be ashamed on asking questions on the things you don't know. Try to learn. Just always show up. The first trick in life to be successful is show up when asked. Then it's God's will after that. Thank you. Thank you to all my team members who showed up today and who contributed to this presentation, by the way.
Thank you again, Dr. Naud, and thank you, everyone. Thank you to those who attended today and the presenters. Great job. And I'd like to thank all fellows who will come and look at the recording later. I wish you all the best. Thank you again, Dr. Naud, for excellent Zoom meeting. Have a wonderful day. Assalamu alaikum. See you next week.